morning, everyone. I'm glad to be with you here this morning to talk about different ways in improving efficiency in cancer care. First of all, I would like to start my presentation with this advance notification that there might be some screams in the presentation. As you know, we are in at home, so I apologize in advance. So the main purpose of this lecture today is to introduce the concept of healthcare efficiency within an economic framework and to explore some sources of inefficiency in cancer care, and specifically considering whether healthcare systems are utilizing their resources in the best possible way, and whether there are opportunities to create savings or efficiencies by reallocating the resources. So starting with some data, this is from a recent local study about the cancer incidence trend between 1999 to 2015. And in the left part of this graph, you can see the incidence cancer in Saudi Arabia that was increased significantly during the last 2 decades as the number of known cases increased up to more than 15,000 cases in 2015, an increase of more than 2-fold in the 15-year period. And the left side is the projection of the number of known cases up to 2030, and it showed that forecast of the non-cancer cases will increase to almost 20,000 cases in 2030, a rise of as much as 63% from 2015 numbers. A further analysis in this study calculated the total economic burden of cancer in Saudi Arabia. The total economic burden was estimated to increase from $8 billion in 2015 to up to $12.3 billion in 2030. And the total cost of all cancer attributable to care management only is projected to be $5.85 billion in 2030, up from $3.6 in 2015. And similarly, the lost productivity is projected to be $6.5 billion in 2030, up from $4.1 billion in 2015. So as you can see, the economic burden of cancer is substantial, and it reflects not only healthcare spending, but also the lost productivity due to morbidity and premature death from cancer. So in the face of limited resources and increasing demand, we need to find better ways of allocating the resources that we have now, and to focus on what can make the greatest difference to our patients. And also, we have to take a whole system view of efficiency, looking across the entire cancer care pathway. So efficiency is a measure of whether healthcare resources are used to get the best value for money. And there are 2 types of efficiency: the productive efficiency, where we can either do it by or achieve it by either reducing inputs or maximizing outputs. The other type is the allocative efficiency, related to allocating our resources to those who value them the most. So in fact, given the financial pressure on the system, coupled with the increasing prevalence of cancer, finding ways to improve the optimum or appropriate allocation of resources to achieve the best possible outcomes for our patients will be the key to the sustainability of our system. But it is very important to note here that efficiency should not be viewed as inducing cost saving. What is critical is to achieve the best outcomes possible for the patients within the resources available. So we will look at the different sources of inefficiency in the system, especially in cancer care. The most important is the delay in diagnosis. as the past few decades have seen considerable advances in the way cancer is diagnosed and treated, and yet with the growing prevalence of cancer and ongoing pressure on the budgets, equal access to the latest advances and the affordability of these innovative treatments have become a challenge. So we've seen significant delays between the time of regulatory approval by regulatory authorities and the real national access for those treatments by our patients. Also, one of the most important sources of inefficiency is the use of low-value care, which means the interventions or treatments with limited benefit. Either they're ineffective treatments with limited efficacy, or they are inappropriate treatments given to the wrong indication, or perhaps if they are not cost effective. Also, the poor adherence to treatments, the medication errors that can lead to unnecessary use of healthcare resources and services, which lead to wastage. Other sources include the underutilization of high technology and equipment, and one area of treatment which is known to be commonly underutilized in cancer is the radiotherapy machines. Also, the unnecessary duplication of tests and services, and the use of high-cost services instead of low-cost services. For example, physicians providing services that can be provided by a nurse, or admitting patients to receive service that can be provided on the outpatient. Sorry. So other important source of inefficiency, especially locally here in Saudi Arabia, is the absence of value assessment, or the inclusion of or the use of pharmacoeconomic or health economic evidence to assess the value of interventions. The lack of real-world data that can help in capturing the variations in the care and the patient-relevant outcomes, and can guide the cycle of improvement and target the care more effectively. So to summarize the first part of this lecture, the potential sources of inefficiency in the systems can include lack of value assessment through the use of economic data, the use of limited or marginal benefit treatments, the underutilization or sometimes overutilization, unnecessary overutilization of services, the medication errors and poor adherence, the lack of real-world evidence, and the delay in diagnosis and access. Sorry. So now we will move to trying to identify approaches that can help in achieving greater efficiency. Well, as cancer treatment costs increase, prevention and early detection efforts become more cost-effective and potentially cost-saving through three strategies. First, the primary prevention strategies that targets the lifestyle modifications such as smoking and obesity, and also through the implementation of quality screening programs, particularly against high prevalent cancers such as breast, cervical, and colorectal cancer, as the greater uptake of those programs is likely to have a positive impact on the burden of cancer. Also through promoting the early diagnosis of cancer with the training of primary care physicians and with the provision of good diagnostic testing infrastructure. Another important approach to improve efficiency is the assessment and uptake of new drugs. As we said, there is delay between the approval from regulatory authorities and the access to treatments or interventions by patients. So early access schemes and managed entry agreements can provide early access to the patients to promising new medicines, whilst on the same time providing an opportunity to collect real-world evidence about the impact or the outcome of those interventions on the patients and on the resource use also. It is also important to consider a full societal value of the new medicine, not just focusing on the clinical outcomes, but also on the impact on quality of life, productivity loss, and also the impact on the caregiver. As we said, using low value care is a source of inefficiency. So we need to eliminate interventions that offer limited or marginal benefit and to prioritize those that give the greatest benefit to our patients and greatest value to the wider system. A key part also of this solution is to develop a better understanding of economic data surrounding cancer care, as they can inform resource allocation decisions. Well, improving cancer care resource utilization requires teamwork, not only by physicians or administrators, but also the involvement of other healthcare providers. And in particular, clinical pharmacists have a positive impact in a high-risk environment, such as, for example, ICU or in cancer care, mainly by preventing avoidable ADRs and complications. As we know, these ADRs can increase and mortality and morbidity, increase the healthcare utilization, increase admission, and extend length of stay, which lead to unnecessary medical costs. Also, clinical pharmacists can participate through the participation in inpatient medication review, counseling, in the consultant-led ward rounds, and also through the development of practice guidelines or drug use policy that can promote the most cost-effective use of treatments. And most importantly, the most important role of clinical pharmacists here is the involvement in formulary management and making shifts to, let's say, more cost-effective options. This is an example of a change or a shift that can be done at formulary level, and that can lead to substantial saving. As you know, a number of biologics now are moving off patent in the next few years, and it is expected to see a rise in the development of biosimilars. Currently, there are some 85 biosimilars have been approved by the EMA, and probably between 20 to 25 approved by the US FDA. And the appropriate use of biosimilars in particular is expected to reduce the spending potentially. This graph is from a recent analysis that showed that the appropriate use of generics and biosimilars between 2015 and 2020 resulted in savings up to 7 billion euro in some European countries, including Belgium, Denmark, France, Germany, and Italy. As I said, using those drugs manufactured by giant pharma companies can lead to substantial savings without compromising the quality of patient care. Other ways to improve efficiency, including the scaling up the use of high-tech devices, or optimizing the use of these technologies, for example, the radiotherapy capacity, and also eliminating the unnecessary use of tests, for example, also the provision of appropriate care and supporting patients beyond the initial phase of treatment, as we know that loss of follow-up during different phases of treatment can lead to substantial unnecessary use of healthcare resources. Also, we need to invest on data to measure the impact of what we do by investing in the right data, and use of this data to drive a culture of continuous improvement with also accountability. So I'll finalize with some other strategies, including the optimized use of workforce. As we said, we should use the lowest cost workforce that can do the service. For example, providing the service of nurse rather than a pharmacist or a physician, if this can be done. And the use of evidence-based driven management protocol that can promote the most cost-effective use of medicines and other interventions, of course. Better control of procedural supplies, and strict policies to minimize the use of overheads, limiting the unnecessary hospitalization and the length of stay. So in summary, these are the approaches that can improve efficiency in cancer care. First of all, prevention programs, early detection programs, and screening programs. The use of health economics and assessing the value of new items to promote the use of the most effective treatments or interventions. It is also important to empower the role of clinical pharmacists, as they can eliminate the unnecessary admissions resulting from ADRs and medication errors. Also, appropriate follow-up through the whole treatment duration, the right investment on data, and optimizing the resource utilization. By this, I end up my presentation. Thank you very much.